Good good afternoon and a warm welcome to one and all. At the outset, I would like to thank all the delegates for being here on the last day of the last session, and thank you for being here. And as all of us know, the technology of multifocal IOLs has been evolving. We started with refractive, then we moved on to diffractive lenses, and we also have the a trifocal or the quadrifocal lens from the PanOptics. So what one should understand is that the multifocal technology is still evolving and evolving. And there's one more technology which is in the market, which is called the EDOF, or the extended depth of focus IOL. When this IOL came into the market a couple of years back, so I had my own doubts why another IOL technology when all the other technologies were already been there, and these lenses still give a good range of vision for most of our patients. But I always tell my colleagues, as the old saying goes, know your patient and treat the patient rather than the disease. Similarly, know your IOL before you know your patients. And that is the best way or the mantra to get success with a multifocal IOL. You really have to understand the IOL, as my previous speakers have told you, understand the technology and select the patient. So with this backdrop, I'll go to my topic. I don't have no financial interest with these lenses. And a small guide on what a multifocal lens does. With a multifocal lens is actually a misnomer. It's a bifocal lens. It has two focal points. One focal point is at focus. The other focal point is not at focus, which causes a glare. The EDOF lens, speaking in pure terms of physics, it has the incident rays of light are diffracted by successive rings by a technology called phase-coded technology, which causes a constructive interference to produce elongated focus. This is something which is very difficult to understand, so put it in simple terms. There are multiple diffractive rings. The light rays are diffracted. They are not made to focus, but they are made to elongate the focus. This is what's simple. So because of the elongation of focus gives you the benefit of these lenses. So what a multifocal lens does, the diffractive ray gratings are on the anterior surface. All the light is distributed to the distance. The patient gets a single focal point, no glare and halos. In a bifocal, there are two focal points, one for distance and one for near. And this near focal point is actually made to focus around 1 to 2 millimeters in front of the macula. So when this and the amount of light that is distributed varies for the near and distance depending on the lighting conditions. So because there's two focal points, you have a glare and halos. You need to understand this to understand the EDOF IOL. So in the EDOF IOL, these gratings are put in the posterior surface, and the profile of the gratings are made in such a way that the light rays are not focused at any particular point, but rather it is elongated to give an elongated depth of focus. So how this is advantageous, I'll be talking on it in my next few slides. So this is an animation which shows you how this elongation of focus happens. And when you add on an aspherical and a chromatic aberration correcting technology to this, it gives you a better range and contrast and vision. And as all of us know, the best IOL to correct your chromatic aberration is your normal single-piece PMMA lens, which has the highest Abbe number. Among the hydrophobic lenses, the EDOF lenses also have the one of the highest Abbe numbers, which reduces your chromatic aberrations. As all of us know, the chromatic aberration accounts for around 2 diopters of depth and focus. So once you correct this chromatic aberration, simply you are able to get another 2 diopters of extra focus, which would be advantageous to your patients. The one thing which you need to understand is the defocus curve. See, normally when you make your patient ametropic, or if you have succeeded in making your patient ametropic, which doesn't happen most of the time, and you put them on the Snellen's chart, and you put in a 0.5 diopter or 1 diopter lens in the trial frame, you'll find the patient vision dropping. But this doesn't happen so when you put in has extended depth of focus IOLs. So this says that the EDOF lenses are more accommodative to the post-operative refractive errors which sometimes happen out of our knowledge. So this is one of the special features of the EDOF lens. So even if you're off your target in the prediction error by a couple of diopters, it's less forgiving on the patient and as the surgeons too. The other important feature is that all of us know about the Strum's conoid, as I'd shown in the figure. The elongation of focus covers the extensive Strum's conoid, and hence even if you have a few post-operative refractive error in the astigmatic part, it also covers this too. And as I told you, as most of our previous speakers have spoken, the centration of the lens is very, very crucial. So even if the lens is decentered by, say, 0.75 to 1 millimeters, the patients actually do not complain because of the elongation of focus. So these are the advantages of the EDOF lens. You can get away with decentration, you can get away with residual astigmatism, and with residual refractive errors also. So this is the basis. So now we know about the lens. So no one will be convinced if we don't have data about how these lens performs in our patients. So this is a single center study where we did a consecutive 106 eyes. This is a photograph of an EDOF lens which is taken from inside the patient's eye. So this is one of the Indian EDOF. To describe this lens has come with the technology of being a refractive and a diffractive IOL. So it has got both these components in it with an addition of EDOF category. The central 1.67 millimeter consists of the 3.3 ad and has got a diffractive component into it. And the remaining part of the lens has multiple diffractive gratings. So to summarize, this particular lens is a refractive, diffractive EDOF lens. So we went ahead and did an analysis at 1 month. It was all a retrospective study. We found that around 90% of our patients had good visual acuity of 6.6 to 6/9. There was a small group of patients which had some refractive error which accounted for the vision of 6/12. The spherical error, as you could see, we had a very excellent spherical error. Only around 2% of our patients had around 1 diopter which is present, but fortunately we didn't have anything fall under the hyperopic category, so we were able to get ahead with the myopic refraction. The cylindrical errors was also similar. We did have a significant cylindrical error of around 15% in 0.75 and above, but as I told you before, these lenses were less forgiving, and hence we were able to get away with these patients even in the presence of a significant cylindrical errors. The near vision was also good. So finally, the take-home message, how to arrive success with these lenses, is that you have to choose your patients well. Select your patients who do not want very good vision from 40 centimeters and near, as Dr. Aravind had put it across. So select these patients well. Do not go for any patients who had a lot of comorbidities with them, or the post-LASIK patients and the traumatic patients also. And the most accurate one is select your biometry. If you could get hold of an optical biometer, it is good, but otherwise you can use the immersion scan. But what you need to keep in mind is that an immersion biometry is around 10 times less accurate than an optical biometer, and the ultrasound biometer is 100 times less accurate than an optical biometer. And so use the latest 4th generation formulas, and any axial length within 22 to 24 millimeters of axial length. Use your normal Barrett's 2, which takes the effective lens position into consideration. Anything beyond 24, use your SRKT, which is still good, and anything less than 22, use your Hoffer's Q, because Barrett's doesn't seem to be more accurate in the eyes or the extremes of thing. And then, as Dr. Minumathan has enlightened, select the patients, very simple surgical techniques, try to do all these cases under the topical anesthesia, but as Dr. Aravind said, it gives the O factor to these patients. Try to get it well-centered, as all of us are good surgeons now, so the biometry is the most crucial factor, and a well-centered lens. So this is what I told about optical biometry, but sometimes when the ocular media is very hazy, these optical biometers do not work well, so in that case you have to go ahead with your immersion microscopes. And what I would advise all the people who are going to start a multifocal IOL, just because some company comes and tells you put in an IOL, do not do it. At least, suppose if you're putting in a Technis IOL, you should have done at least 20 to 30 cases of the monofocal counterpart, refined your surgical induced astigmatism, refined your prediction errors, and then you go ahead with a multifocal. Don't just start multifocal from the beginning of your practice, because refining a prediction error is very important. Modify the A constant also depending on the different lenses. Go to the ULIP calculator where you find the different amounts of A constants which are present, and then go ahead with the multifocals. the latest formula, which is the RBF formula, which is actually a very excellent tool. It works like how a biometry works for an attendance system. The more amount of data you feed into the system, the more accurate the RBF fills. It could take another couple of years for this formula to be used worldwide. And finally, my acknowledgements. Thank you.